All right, hey y'all. I'm gonna go ahead and get started here. I apologize for my screen. For some reason, I can't put it on full screen. My computer glitches out, so we're just gonna have it like this. So my name is Anand Sahama, a medical student at University of Tennessee and a outgoing board member for PNHP. It is my absolute distinct pleasure to be here with you. I am actually going to serve as the hype man or the opener for Daniel Geiger, who is the current AMSA Education and Advocacy Fellow. And it's an absolute privilege and pleasure to have him speak with us, since this is exactly what he does full time with all of his time. And he's an incredible resource, incredible presenter, and we are so lucky to have him. So I'm just going to take a few minutes of your time and tell you a little bit about just kind of PNHP specific advocacy, and then we're going to move to Daniel for the remainder of the time, who's going to talk about advocacy on the national level, on the Hill, everything he's been doing, and try to put PNHP in the context of health policy on the national stage, right? So I'm just going to go ahead and get started. So my presentation is on how to stay informed, stay engaged, and stay organized. Wherever you are in your kind of tenure with PNHP, hopefully you can take something, whether you're trying to start a chapter right now or you've had a chapter for several years. Hopefully you can take something from these presentations. All right, so the process is you want to strategize, you want to recruit, and you want to take action. So just trying to break this down into 3 steps. So of course, strategizing is really important. You always want to organize yourself, and you always want to keep educated. Once you strategize recruiting, of course, you want to reach out, you want to grow your base, and then you want to take that organization and take action. So that's forming coalitions with other groups to grow your numbers, doing creative programs to inform others, or one of many other different things. So how do you stay organized? So my biggest advice to anyone, just starting off in advocacy work is a location to centrally store your files. Harness the power of the cloud. So if you have something like Dropbox or Google Drive, you can easily put everything in there and then share it amongst your colleagues very, very easily. Included in that is you want to always have a template of your chapter constitution and a template for your PNHP charter. So if you're at the very beginning, of course, this is one of the first things that you do is draft a chapter constitution with your fellow members, and you draft your PNHP charter. So you always want to have that accessible, just to see kind of where you are as a chapter and where you're going, and how to deal with things like turning over leadership for the next year, or how to have meetings, how to make decisions, and stuff like that. So have those always available and accessible, and of course things like taking minutes for every meeting, stuff like that, locate them centrally in some cloud format. The other thing is make a list of targets you want to contact at each school. So I'm actually a transfer student. I actually started my medical school at East Tennessee State, and I'm actually at University of Tennessee now. So at both schools, I kind of made a list of targets of both faculty members and students that I wanted to contact, and just made a running list of that, and kind of kept a running list of whether I have contacted them, what their reaction was, how involved they want to be, etc. And we actually grew that list in Memphis to the community. So now we have a running list of physician targets and non-physician targets, actually. So nurses and other healthcare workers, and actually even community stakeholders, just people to target and people to reach out to. So we keep a running list of targets like that. And actually at University of Chicago, they took it one step further, and they took that list and formed a pretty tangible base of supporters out of that, which is incredible. And one thing really, really important that you have to ask yourself constantly is, what is success like to you? So advocacy work, as Daniel will talk about, is very, it's very time consuming. It's very frustrating at times. So make weekly, monthly, and annual goals, and how will you not get discouraged? I'm currently in my M3 year now, and my weekly, monthly, annual goals for advocacy are very, very, um, it's a low bar. It's a very low bar. I don't have much time to. I won't get discouraged. Probably the most important side here is to educate yourself. So knowing single payer is obviously the first step. If you take anything away from this presentation, it's to subscribe to Dr. Don McCann's quote of the day. This is a very, very invaluable resource. Every day he basically takes a health policy article and um, he puts that at the top and he quotes an excerpt out of it. And at the bottom, he provides his thoughts. So it's a very good way to keep your pulse on what's going on in the nation in terms of healthcare policy and how to put that in the context of our single payer movement. The other thing is PNHP keeps a running blog of articles of interest. So you can actually click that link and it'll take you to an up-to-date blog of articles that have been posted by advocates around the nation for single payer. Two things that are absolutely essential reading. Read the PNHP physician's proposal for single payer. It's very, very approachable, very short, but it kind of shows you, or it does show you where we are and where we want to go as a movement. And Healing of America by T.R. Reid is a book that I can't recommend enough. It's T.R. Reid actually, he had a shoulder injury and he traveled to many different countries and asked for treatment for his shoulder injury, and he writes a very, very approachable and very it's a book written in prose style, so it's not policy heavy. It's not in the weeds per se, but it's a very good book on exploring the healthcare systems around the world. And of course, keep your pulse on healthcare policy. Our movement is, unfortunately, it's only one piece of healthcare policy, but we want to be a bigger piece. So how do you keep your pulse on healthcare policy? Again, Dr. Don McCann's quote of the day, and two resources that I use is Kaiser Health News puts out a briefing every morning of the rundown of healthcare policy, and I do have sometimes long drives to work. So I listen to Politico's Pulse Check podcast, which is very good, very, very accessible podcast. And of course, perfect your 30-second elevator speech. And you can go to pnhp.org's FAQ and see a good rundown of the most common questions that are asked and how to approach those questions. These are two resources that can help you perfect your elevator speech. Vox put out a 2-minute video, and PHP Minnesota, which is a very, very vibrant chapter, who does they do an incredible amount of great advocacy work there. They also put out a 1-minute video. So once you are organized, how do you recruit and reach out? Single payer 101 or grain rounds are very, very good ways to get your feet wet and to introduce single payer to your school, your community, whatever it may be. And there are plenty of single payer 101 presentations out there. I have one I can send to you, or there's many that are in the PNHP database as well. Panel with physicians and or other advocates is really good because that's interactive and that allows the audience to grill the physicians per se. And it's even better if you get physicians that are non-PNHP as well and see what they can come up with too. Having movie screenings is very, very easy to organize and very accessible. Two really good ones are Fix It or Sick Around the World, and both of those have a shortened 35 to 40-minute version that you can show during lunchtime. So that gives you enough time at the very beginning, 10 minutes, for everyone to get their food, and then at the end, 5 to 10 minutes for Q&A, which is perfect. Values Clarification Workshop is a activity that one of my colleagues, Annie Koleric, who's now a family medicine resident at University of Tennessee that she came up with, and it's really nice. It's tough to explain succinctly without showing it, but it's basically kind of a case-based look at single payer. So it takes you through different cases and and sees how insurance and how financing healthcare ties into healthcare outcomes. So it's very, very good. And all of these are available online, and we can go through where to find it if we have time at the very end. Growing your base. So aim for lunchtime, have food, but think outside the box. Not everybody wants pizza. If you have something that's not pizza, that is even better. Remember, PNHP will subsidize this. So please coordinate with PNHP about this. They will subsidize your food and reimburse you for event costs. Have a sign-up sheet so you know who comes and you know who to keep in contact with. And it's even better if you have an immediate action at the very end to get involved. Either at the end have a resolution that somebody they can sign, or have some type of action that's going to take place next, or a meeting that's going to happen next. So always try to keep that momentum going. An example of a good resolution is, of course, the PHP Minnesota chapter. As you can see, their resolution is, what, 2 sentences long, and at last check they have several thousand signers on here. So strategy without action is pointless. So always have something tangible that people can hook onto. Once you've kind of grown your base, take action. All right, form coalition. Nurses, public health, and other healthcare professionals are great targets for forming coalitions. Trade unions are very, very natural targets. PNHP has historically had a very, very good partnership with local trade unions and national trade unions as well. Social justice groups like White Coats for Black Lives or Healthcare Now, they are very strong partners of PNHP. And believe it or not, healthcare lawyers are actually very invested in healthcare policy. That is actually one of my interests right now, is to improve medical legal partnership and see how that ties into healthcare. So I have a lot of investment in that. So this is kind of segueing into Daniel's talk about how to take action. So I won't go too much about it, but some ideas are a day at the state capitol on the Hill, or quote unquote bird dogging, which is meeting with your local representatives and getting them on record for what they think about single payer. Having op-eds or letters to the editor, and anything to educate or rally the public. And finally, be prepared. I can't stress this enough. The biggest way that I stay prepared is just to be informed of what's going on day to day in healthcare policy. I don't have a lot of time, of course, in third year, but if I take 15 to 20 minutes out of my day to just see what's going on in the national conversation, that's a win for me. And I do that through Don McCann's blog, Politico's Pulse Check podcast, if I have a chance, and just skimming Kaiser Health News and trying to skim the articles of interest on PNHP just to see what's going on. So these are some questions you have to be prepared for. And the conversation is heating up right now, so you have to be prepared to answer the big hitter questions. Right? And this is my contact information. This email is probably the best way to reach me. And I will change it over to Daniel, and we can do a Q&A at the end for all of us.
Okay, thank you so much, Anand. Oh no, you saw my ending meme, that's funny. Well, so thanks to the Students for a National Health Program for inviting me to come and talk to you all. My name is Daniel Geiger. I'm the American Medical Student Association Education and Advocacy Fellow. I actually graduated from East Tennessee State University Quillen College of Medicine, which has a very robust SNAP chapter and AMSA chapter, thanks to Anand and several of our medical students at Quillen who are very invested in organizing. And so, like I said, thanks to Anand. And in terms of staying encouraged and the things that he brought up, there's a lot of value to that. And if there's any piece of advice that I could say to any of you, it would be to value incremental change. And we're really going to kind of get into that because that's part of advocacy and organizing fundamentals. So today, what I want to talk about is we're going to discuss health policy as just an overarching concept and what that really means. And then we'll transition into comparing and contrasting how that is with the fundamentals of advocacy and community organizing, and we'll talk about some examples of that within the frame of single payer, but also recognize that advocacy and organizing as a concept is something that's transferable to multiple issues. So whether or not you're interested in single payer and Medicare for all, or if you're invested in reproductive health justice, if you're invested in medical education and larger issues of health equity, these core skills are things that are transferable to multiple issues. And looking at all of the things that are happening within the political landscape, it's really difficult to sort of say, well, which is more important? And if you have a strong foundation in these core fundamentals, then as you continue on in your medical education and training, as you continue on in your practice, then you can be a strong participant within the larger civic environment. So moving forward, today we're going to talk about, because I'm an educator, we've got some learning objectives. We're going to start out and talk about, basics of policy, power, systems at a very core definition kind of level. And I think it's important to start there because sometimes we get so invested or focused in on a narrow issue that we forget the larger 30,000-foot view. And I know that it's pretty variable as to how well medical schools teach that. Then we're going to talk about policy, a little bit about legislative process, which is really confusing, and we won't go too much into that. But we're going to spend a bit of time talking about the organizing cycle, framing and values, and really apply that to a single payer and talk about what is our role as physicians and medical trainees and people within the healthcare workforce. So to start, let's talk a little bit about power and politics and policy. And this is a really interesting question that many people actually struggle to do, but can we define politics? What is politics? The School of Public Health at Harvard actually defines politics as something really simple. So just politics is the way that we as a society decide who gets what, when, where, how, and why. And actually, let me make this bigger so that you all can see that. So politics is the way that we decide who gets what, when, where, how, and why. And that's really interesting as a definition and moves forward into talking about policy and power. So let's talk about power first. This is a video that I hope plays. You all send me messages in the chat function if it doesn't.
Every day of your life, you move through systems of power that other people made. Do you sense them? Do you understand power? Do you realize why it matters? Power is something we're often uncomfortable talking about. That's especially true in civic life, how we live together in community. In a democracy, power is supposed to reside with the people, period. Any further talk about power and who really has it seems a little dirty, maybe even evil. But power is no more inherently good or evil than fire or physics. It just is. It governs how any form of government works. It determines who gets to determine the rules of the game. So learning how power operates is key to being effective, being taken seriously, and not being taken advantage of. In this lesson, we'll look at where power comes from, how it's exercised, and what you can do to become more powerful in public life. Let's start with a basic definition. Power is the ability to make others do what you would have them do. Of course, this plays out in all arenas of life, from family to the workplace to our relationships. Our focus is on the civic arena, where power means getting a community to make the choices and to take the actions that you want. There are 6 main sources of civic power. First, there's physical force and a capacity for violence. Control of the means of force, whether in the police or a militia, is power at its most primal. A second core source of power is wealth. Money creates the ability to buy results and to buy almost any other kind of power. The third form of power is state action, government. This is the use of law and bureaucracy to compel people to do or not do certain things. In a democracy, for example, we the people theoretically give government its power through elections. In a dictatorship, state power emerges from the threat of force, not the consent of the governed. The fourth type of power is social norms, or what other people think is okay. Norms don't have the centralized machinery of government. They operate in a softer way, peer-to-peer. They can certainly make people change behavior and even change laws. Think about how norms around marriage equality today are evolving. The fifth form of power is ideas. An idea, individual liberty, say, or racial equality, can generate boundless amounts of power if it motivates enough people to change their thinking and actions. And so the sixth source of power is numbers, lots of humans. A vocal mass of people creates power by expressing collective intensity of interest and by asserting legitimacy. Think of the Arab Spring or the rise of the Tea Party. Crowds count. These are the six main sources of power, what power is. So now let's think about how power operates. There are three laws of power worth examining. Law number one, power is never static. It's always either accumulating or decaying in the civic arena. So if you aren't taking action, you're being acted upon. Law number two, power is like water. It flows like a current through everyday life. Politics is the work of harnessing that flow in a direction you prefer. Policymaking is an effort to freeze and perpetuate a particular flow of power. Policy is power frozen. Law number three, power compounds. Power begets more power, and so does powerlessness. The only thing that keeps law number three from leading to a situation where only one person has all the power is how we apply laws 1 and 2. What rules do we set up so that a few people don't accumulate too much power and so they can't enshrine their privilege in policy? That's the question of democracy. And you can see each of these laws at work in any news story. Low-wage workers organize to get higher pay. Oil companies push to get a big pipeline approved. Gay and lesbian couples seek the legal right to marry. Urban parents demand school vouchers. You may support these efforts or not. Whether you get what you want depends on how adept you are with power. Which brings us finally to what you can do to become more powerful in public life. Here, it's useful to think in terms of literacy. Your challenge is to learn how to read power and write power. To read power means to pay attention to as many texts of power as you can. I don't mean books only. I mean seeing society as a set of texts. Don't like how things are in your campus or city or country? Map out who has what kind of power, arrayed in what systems. Understand why it turned out this way, who's made it so, and who wants to keep it so. Study the strategies others in such situations used. Frontal attack or indirection. Coalitions or charismatic authority. Read so you may write. To write power requires first that you believe you have the right to write, to be an author of change. You do. As with any kind of writing, you learn to express yourself, speak up in a voice that's authentic, organize your ideas, then organize other people, practice consensus building, practice conflict. As with writing, it's all about practice. Every day you have a chance to practice, in your neighborhood and beyond. Set objectives, then bigger ones. Watch the patterns, see what works, adapt, repeat. This is citizenship. In this short lesson, we've explored where civic power comes from, how it works, and what you can do to exercise it. One big question remaining is the why of power. Do you want power to benefit everyone or only you? Are your purposes pro-social or anti-social? This question isn't about strategy, it's about character. And that's another set of lessons. Remember this: power plus character equals a great citizen. and you have the power to be one.
Okay, so that video is supposed to be thought-provoking and provide a framework for us to work forward from, because we're really talking about looking at large macro systems and determining how we make asks for change, and that's going to come in a little bit later. But another thing that this video really points toward that we talk about within public health is the social determinants of health. And depending on where you are in medical school, you may or may not have already addressed the social determinants of health. If you have public health background, then certainly you've heard of these things. But the social determinants of health are these underlying larger infrastructures that have much more of a greater influence on overall health outcomes of populations than any individual disease process, pathology, microbiology, etc., or even behavior of an individual or a family. And this is a really famous quote from that many people in public health use, is that your zip code is just as much a predictor of your health as your genetic code. And that's, again, worth pointing out, even if you've been around PHP for a long time, because this is really underlying principle. So what we do know then is that, well, what is policy? So, the video talked about policy as a way to freeze power. Policy is also a way to shift narrative. And frequently within medicine, what we do is we look at some of this downstream intervention. So looking at disease and injury, we diagnose patients, we see patients, we put together their constellation of symptoms and objective findings and prescribe treatments, or we try to alter the individual or the family's behavior, so stuff like smoking and alcohol and drugs and sexual behavior. But what we really know within the public health space is that some of these upstream narratives, all of these upstream narratives, whether or not we're talking about living conditions like food insecurity, housing insecurities, whether or not people are employed, they have access to healthcare, and then even further up within the institutional inequities of things like, do you have schools within your district? Do you have voting places within your districts? Do you have adequate business structure within the place that you live? What are the laws and regulations like in terms of governing a particular region, all the way up to the larger social inequities of discussions surrounding race, which I know that you all have had in some of your prior webinars, class, gender, all of these different axes that create overall inequity within the health space, but in the social space in general. These things are much more influential. And what's really important is for us to understand that policy is something that shapes every single point along this continuum. And so it's important for us as physicians and medical trainees to engage within this space. So policy, you may have seen this diagram before, but if we think about like who influences the healthcare system, there's the 5 P's that we really talk about. Patients, providers, purchasers, payers, and policymakers. And this is a slide from the Introduction to U.S. Health Policy course from Harvard School of Public Health. And we've had discussions all throughout SNAP and PHP about payers. So payers are, people like private health insurance companies versus the government. Purchasers can be individual purchasers, they can be employers, etc. Providers are people within the healthcare workforce, so everything from, physicians, pharmacists, etc. Patients, of course, are patients. And, policymakers are our legislators and elected officials, or really anyone in power. And that's the way that I want you to think about it. So think about these things as like 5 arms on a tree, and we see all of these different leaves and branches to show that each area gets more and more complex. There's lots of different types of payers, there's lots of different types of policymakers. What's important to understand is that each of these different 5 major buckets influence healthcare within a very important and meaningful way. So if we're going to talk about policy analysis is By definition, the systematic examination of a problem from the perspective of a particular stakeholder, okay, and it helps to make a choice that's reflective of values and is practical and political in terms of what is feasible in reality. So practical meaning evidence-based and fact-based. The point about a policy analysis is that it kind of sort of works through a logical decision-making process. There's a background, there's a landscape, you talk about the ethical and moral political sphere, you look at options and have defined evaluation criteria. The point about policy and policy analysis is that it's methodical, it's rational, it's logical as an approach to decision making. And that's something that we all value, and that's something that's really important, because we certainly need to implement policies that are evidence-based and meritorious. But there's more to overcome than just a good policy when it comes to decision making. And that's important to think about whenever we're talking about single payer, because the policy can be great, but if it's not politically feasible, or we're not somehow conveying that message to influence our decision makers who have power, then that's where we really struggle. So very briefly, just to review how a bill becomes a law, I don't want to get too far bogged down into this because we have other things that are probably a little bit more important to talk about. But this is very US government 101, but if you all were like me, I had to review this extensively because my US government teacher in high school was a football coach. So I didn't really learn a whole lot of things. But summarize it to say that a bill is introduced within one chamber of Congress, whether or not that's the House or the Senate. It gets referred to a committee, which then puts a bill into a subcommittee, and a bill goes through multiple phases of markups out of subcommittee back into the larger committee and eventually all the way to the full floor of a chamber for voting. If a bill passes one chamber, it has to go to the other chamber and essentially go through the whole committee process from subcommittee up again. And once a bill has been passed by both the House and the Senate, then the two final versions of the bill kind of have to go through a process where they get mashed up together so that there's one final thing. We saw that with the tax bill, for instance, back in December. And then that finalized bill goes on to the president for signature, which can then either be signed into law or it can be vetoed. So the point about it is that there's multiple processes multiple phases within the legislative process. And in terms of engaging our elected officials, there are multiple points of intervention. And that's what's really salient about this slide. Legislative process is much more complicated than this. This is a very distilled version, but it's important to review to think about, well, how can we engage our elected officials? I don't want to spend time on the federal budget process because that's even more complicated. Surmise it to say that there's a budget proposal. Budget has to go through resolutions. This gets into whether or not spending at the federal level is discretionary or non-discretionary. This is a whole separate talk that we could certainly spend time on, but if you want to continue like what Anand talked about and educate yourself and really understand the key fundamental principles of how our legislature works, how the federal budget works, and how it gets made, because that can actually really help understand policy proposals too. So this is a phrase that we hear a lot on Capitol Hill: laws are like sausages, it's better to not see them being made. And that's really true because it's complicated and it's messy and it takes a long time, or well, it should take a long time. So I don't want you all to feel too bogged down about that if you don't understand completely legislative or budget process. But what I really want you all to take away is that policy analysis and working within the policy space and facts and evidence, all those things aren't enough, because there's something else that's bigger that drives decision making. And that's where we really get to talk about advocacy. Advocacy and policy analysis are really two sides of the same coin. So let's talk about how do we influence policymakers to make decisions, and what is all of this advocacy talk that we hear so many times. So this is an exercise that I do with students pretty regularly. This is a thought question. So I've got multiple pairs of words down here, and I want you to pick which is the stronger driver of decision making. So content or context, and just think to yourself, which of those two drives decision making? beliefs or facts, and evidence or story. Of these word pairs, which are the stronger drivers of decision making for anyone, a general person? So it's interesting when I do this in a classroom, because a lot of the times you'll see people answer different ways depending on the word pair. And this is really the same question asked 3 different ways. So context and beliefs and story are all really the same thing, and content and facts and evidence are all really the same thing. The reality is that people make decisions based off of their beliefs and the context and the story that they're told, not necessarily content and facts and evidence. And so now we start to see some differentiation between policy analysis and working in that very intellectual space versus advocacy, which is working within, the values in the human space, and understanding that there's more to just content and facts and evidence. And this is what we think intellectually would work well to actually getting people to buy in to something that you think is important. It involves influence. So let's really spend some time and actually talk about what is advocacy. And in order to do that, we should probably talk about what is not advocacy. So advocacy isn't fundraising or charity. It doesn't mean that fundraising or charity isn't important. Certainly, fundraising for a nonprofit or contributing to charitable organizations is a worthwhile cause, just like community service is a worthwhile cause. Going and volunteering within an organization that you care about. All of those things are important, and that's not to, this discussion isn't to degrade those in any way. Advocacy is not lobbying either, and you'll hear many people, even within the government relations space, utilize those words interchangeably. But I draw a distinction for medical trainees and physicians between being advocates and being lobbyists, because a lobbyist is a very defined thing from the actual legal space. Lobbyists have to be registered. Lobbyists have to do quarterly reporting. Lobbyists are employed by quarterly reporting of their political contributions and campaigns. Lobbyists either work, independently, or they work for an organization that hires them. They represent firms. So that's very different from a physician, even if you're working through an organization like Physicians for a National Health Program, or if you're working through an association like SNAP or like the American Medical Students Association. So as a medical trainee and as a physician, your role as an advocate is very different, because you're representing a community. You're a constituent, and you're a constituent that has a certain amount of expert knowledge within a subject area. And so because you represent constituents, your voice means something different to elected officials from a lobbyist. And so that's why I make those distinctions, because your voice is more important. Your voice is louder. Now, speaking of voice, though, it's important to remember in the advocacy space, regardless of whatever issue it is that we're discussing, that, as healthcare professionals, we're not a voice for the voiceless. If we're talking about single payer, or we're talking about reproductive health justice, if we're talking about housing insecurity, if we're talking about drug abuse, we're not a voice for our patients, because our patients can speak for themselves. If we occupy the space of being a voice for someone else, then what happens is that we shift the power to ourselves and not empowering our communities. As physician advocates, as medical training advocates, our role is to take the social issues and take the voices of the people for whom we care and amplify those so that their perspective is heard. We use our platform like a megaphone, and that's an important distinction. So advocacy really is, and it's about taking a strategy, which we'll talk about strategy in a little bit, but we analyze power structures, like in the video that we talked about. Who holds power, who makes decisions, who influences decision makers, and how do we approach that space with a strategy and in the overall system to ultimately make an ask for change. So advocacy really is about analyzing power and making asks for change. advocacy is something that is very much supported by all of the different professional associations as a core tenet of professional identity in the healthcare space. So advocacy is not something that's extracurricular or that we do whenever we have free time. Advocacy should be something that we incorporate within our daily practice as much as we can. And before I get into that, one of the ways that I really like to try to illustrate the concept of asking for change, and also illustrate that advocacy is uncomfortable, or it can be uncomfortable, is utilize a public health analogy. So in the public health space, let's pretend that we're all a group of students, or we're all just friends, and we go to a lake to go camping, and we're going to go kayaking. So Anand spoke a little bit earlier. Anand and I are going to take our kayaks, and we're going to figure out where's the best place for us to set the kayak out into the lake or the river. So as we get down to the edge of the shore, we look out into the lake or the river, and Anand and I see a body face down in the river. So everything is urgent. He and I swim out. We pull the person to shore. We flip the person over. We start going through our ABCs, trying to resuscitate the person, make sure that they're okay. We keep working, and I look up and I see someone else out in the river face down. So Anand continues to work on this person. I go out and swim and get the other person. Now he and I are working together to try to revive these two people. We've been gone for a long time. People earlier in the group from the campsite start coming down to see what's going on. They see everything that's happening. They look down. They're like, oh my gosh. And we continue working on these two people, and then someone looks out and sees a third person out in the river. So they swim out, pull them to the shore, and we continue with this whole process because we see continually bodies in the river, pulling them to shore, trying to revive them. We set up an elaborate process. We start saving some people. We quote unquote do good. But in all of that, who took a moment to step back and say, why are their bodies in the river in the first place? And more importantly, if you did take a moment to say, why are their bodies in the first place in the river, then what can we do to change there being bodies in the river in the first place? So that's sort of an allegory to illustrate that asking for change within large systems is sometimes uncomfortable. Determining who has power is strategic and also uncomfortable. But it's a skill set, and we can practice it, and we can apply it to any type of issue. And we can do that at least one way, through storytelling. Stories, Anand mentioned, sharing patient stories, I think, and some of your other webinars have certainly talked about sharing patient stories and sharing our expert knowledge that we have working within the healthcare space. And that can really influence our elected officials in a much broader way than just facts and evidence. We'll talk a little bit about the champion scale. So you all have probably heard of the champion scale. I like to draw a comparison to the readiness to change scale that we actually talk about in medicine. Many people haven't probably heard it in that context, but think about to your lectures in med school that you've probably heard regarding smoking cessation. Struggle on that word. Quitting smoking. There you go. So the quitting smoking readiness to change scale is someone pre-contemplative or contemplative or ready to change. You remember all that. So what that looks like is you've got, a 65-year-old man who's been smoking for 25 years, 2 packs a day in your office. You ask him, has he ever thought about quitting smoking? He says no, because he likes to smoke after he eats, and he does it to de-stress. And then you're like, okay, well, how much do you smoke a day? And he says, well, I smoke 2 packs a day, and I feel fine, despite the fact that he's coughing up green stuff all the time, right? And so then you ask him, well, what do you like about smoking? And he says, well, it relaxes me, and I get to do it with my friends and family, and we sit around and we talk, and it's a social thing. And you say, okay. And you say, well, what do you not like about smoking? Well, I don't like the fact that I spend so much money on packs of cigarettes. They've gone up. And so then you ask the question, well, on a scale of 1 to 10, how ready would you be to quit smoking? And he says, about a 2. And you say, okay, well, what would it take to get you from a 2 to a 3? And then he's really uncomfortable and angry at you because he's like, you're never going to let this go. And you're like, no, I'm not going to let it go. So what would it take you to get from a 2 to a 3? And he said, well, I would probably have to figure out a way to, eat better, or he throws something in. And so the point about it is that you figure out what's important to someone and you gradually move them up along that scale. Well, this is the same thing, only applied to elected officials. This is figuring out what is their values, what is important to them, how do we get within their frame, and how do we take our issue that we care about with the facts and the evidence and the policy that supports it and put it into something that will help them move along the champion scale. That's the concept. And the reality is that, especially as constituents and as medical trainees and physicians, people working within the healthcare space, we matter. This is data actually from staffers and aides and legislative directors on the Hill. And what we see is that in-person visits from constituents, phone calls from constituents, any kind of contact from a constituent is significantly more influential on an elected official's decision making than a visit from a lobbyist. And this slide is the reason that I make a distinction between your role as a physician or a medical trainee versus as a lobbyist. So let's talk a little bit about framing and really suss all this out. So you've probably heard the word frame and framework and all of these things thrown around policy, but let's break it down. A frame is just a conceptual structure. It's a schema, if we're going to use the psychology words. But a frame is essentially a story. And it's important to understand that words have meaning and words create frames. And I've got some examples of that. So let's look at something that is arbitrary. An elephant. So we've all seen elephants. We all know that elephants are big, and if elephants are animals, they're gray, they have floppy ears. If I were to tell anyone here that elephants are pink, they would think that I were crazy because they've never seen a pink elephant. I mean, maybe unless you've, watched Dumbo or something like that, but you've never seen a pink elephant in real life. And so you refuse to believe that elephants are pink. Even if I presented with all kinds of data that elephants were pink, it would be really difficult for me to convince you that elephants were pink until you saw a pink elephant, or until something about your value structure changed to say that elephants could be pink. And then it's more likely for me to convince you of that. So that's an arbitrary example. It has more meaning whenever we apply it to actual political issues. So let's look at the frame of tax relief. We talk about tax relief and taxes in policy a lot. So taxes could be looked at as a duty, or like a civic duty, or an investment in the United States. Taxes can be looked at as enabling government to function, or empowering government to function, if we think that enable has a negative connotation as a word. Taxes could also be viewed as an affliction or very anti-American and separatist. Taxes could be seen as a representation of government waste. And so whenever we talk about tax relief bills, what do the words tax relief do? Well, if you say tax relief, relief creates the frame that taxes are a burden. So it puts it into that negative connotation. If we say relief and taxes are burdens, then the people who relieve the taxes, i.e. the policymakers who alleviate taxes and create that feeling of relief, are saviors. They frame themselves in a positive way. So that's how framing works. And so it appeals to the core value of whether or not someone is supportive of government and taxes or not supportive of government and taxes. And maybe that's very absolutist and black and white, but it's important whenever we're talking about any policy issue to really be declarative and be defined about what value systems are within an issue that we're discussing. So here's another really powerful example of framing at work. So this is actually just from the other day. This is a tweet from Senate Majority Leader Mitch McConnell. Whenever during the government shutdown, discussions between CHIP or DACA. And this is an image that was on Twitter, but it has incredibly powerful framing. So let me just show you the things that I see within this photo. I see with symbology or symbolism in this photo that there's a contrast of good or bad. I see something as literally being white or black, meaning that there is no gray within the decision. I also see that this is making DACA look black. Black can mean evil. This could also be illustrating DACA exclusively as people of color. This could illustrate DACA as being bad. This illustrates DACA as being inferior. All of those different things that can be associated with a dark color, and it's not even a word. We also see red at the top, which illustrates that this is something that's urgent. And so this is very polarized of a decision. And of course, we could also go on for days and talk about that this is a false equivalence because it's still vulnerable children. But what we see on the left is that this is illustrating children on the left as being vulnerable, needed to be protected. They need white, they need a savior, maybe they are white. The people on the right-hand side, the DACA recipients, are children who don't deserve being protected, who aren't American, who are lesser, who are sullied. There's a lot of frame and a lot of illustration and something that's really powerful that goes into an image, and that's not even without any of the words. That's the value of framing. And why is it important to point that out? Well, if you are a voter who already has within your frame that persons who are undocumented or DACA recipients are sullied or are unworthy or are quote unquote illegal, then this plays within your value system and you support it. That's the power of framing. And so the point is that a frame determines what truths a person is likely to accept. If the truth does not fit the frame will stay in place and the truth will dissipate. So this discussion about values is what's so important when we talk about advocacy, because we have to figure out how to frame our issues, not only in merit, fact, policy, evidence, but also within values. So what does that really look like for Medicare for All? Well, the meritorious messaging that we see a lot from the policy space is, Medicare is a single program, so it could streamline. We see Medicare as comprehensive, free at point of service. We talk about universal coverage of all people within the United States. We also talk about framing the merit base of Medicare for All as being accompanied by like a jobs plan to replace the lost workers that we would have from removing other payers within the space. This is all merit-based messaging. It's important and appeals to some people who make decisions based partially off logic and content, but it's not really how people make decisions. So what are the values questions that we should ask when it comes to Medicare for All? So values questions are things like, is healthcare a human right? Should healthcare be tied to employment in the first place? The connection between health insurance and employment actually dates back into the 40s from the Roosevelt administration in the post-World War II era, whenever there was such a decrease or such a shortage of labor and increases in prices and wages that the Roosevelt administration actually put a price and wage freeze in the early 40s. And as a result, employers began offering tax-free benefits like health insurance as a way to incentivize people to come and work for them. So employer-based insurance actually comes in the United States healthcare delivery system as a result of, a casualty of war, if you want to think about it. But it's been like that for so long that we should really challenge people to ask ourselves, should healthcare be something that's tied to your employer now anyway? Does healthcare access promote or detract from self-reliance? There are many people that look at things like Medicaid as equivalent to welfare because it's all lumped within the social safety net, and the concept or the value of self-reliance is one of those key tenets that sort of distinguish conservative versus progressive ideology. We should also talk about whether or not talent and opportunity are equally distributed, meaning as long as you pick yourself up by your bootstraps, you can be successful, versus it doesn't matter how talented you are if you aren't presented with the opportunity. In other words, you don't have shoestrings within your boots in the first place, you're never going to be able to pick yourself up. These are values level questions. Another important question we should ask is, do we look at the government and say that the law is in place to protect by the government or protect us from the government? If within the healthcare space, if contributing to a universal healthcare program isn't equal, then is the benefit universal to everyone? These are questions that are all pointed out within or many of them are pointed out within Atul Gawande's Is Healthcare a Human Right? It's a very provocative piece, well written, of course, because it's by Dr. Gawande. It was written in the New Yorker in 2017, and these questions I can't answer for you. I don't think that many of us have answers to these questions, but these are the things that are going to help frame and strengthen messaging much more than all the facts and evidence and data. But what we do see is that, as a result of the healthcare bills over the summer and really over the last year and a half, is that the messaging around healthcare delivery in the United States is changing the base. We see that in the data. In 2017, more and more people are talking about that healthcare delivery is and should be a responsibility of the government. So the value is there. We just have to continue on with the messaging. This concept of activist and agent is kind of what I talked about in my allegory earlier with, the river. Activists are people who step back and ask to change the system. So we either can work within an existing infrastructure that's broken, or we can step outside it and figure out how to retool it. And that's what this really is about. So I want to spend a little bit of time on the organizing cycle. The organizing cycle is a series of phases within any type of community building or focus on an issue to try to win people on your side. Anna mentioned some things surrounding direct action, like writing letters to the editor or op-eds, or organizing rallies and bird dogging and things like that. That's just one sort of area of action within community organizing. The reality is that community organizing is a huge cycle, and depending on the political climate, working within one particular area may actually be more fruitful. So we talked earlier on and mentioned about, how do we stay encouraged and don't get discouraged? And my take on that is to value incremental change and recognize within a given environment what area of the organizing cycle is most successful, or is probably more fruitful to work in. So, right now, what we know is that we have a very politically contentious climate. We know that the current administration puts out proposals and tweets and executive orders and bills every day. And how do we get everyone to care about our issue within the policy space when there's so much going on? And so the reality is that, maybe base building as an area of the organizing cycle might be a fruitful place that we can actually make change. So within base building and building a community movement, we can talk about grass tops and grassroots organizing. Grass tops is talking to people with power. So looking at people like your school deans or your healthcare system presidents. Grassroots is local voting members, your other medical students, your people out in the community. And in community building, we really talk about the rule of thirds, meaning you're going to have a third of people who are really engaged in your issue and care. You're going to have a third of people who are passive and don't have an opinion. And you're going to have a third of people who are opposed to your ideology. It's really easy, or the tendency is to try to go for the people who are opposed and convince them, which is kind of sort of like beating your head against a wall. And so it's actually a better strategy to work with people who are already actively engaged in your issue or who already care, and be sure that you build out those values. People can talk about the policy, people can talk about why things matter, they can share their stories, because then what happens is you build your base and the base spreads into those who don't have an opinion. That's a much more fruitful and productive approach than trying to convince all of your opponents what matters. And so in this environment, in this time, it may be better to actually work on building bases. And that can be all types of, even webinars like this are geared at community education. And that doesn't mean that there isn't a role for action. And we certainly still need to raise attention and awareness, and action can certainly do that. And there's lots of different types of action that we can take to raise awareness on an issue. So when we talk about action and influence, we can talk about direct action, which is this whole spectrum of examples of things that we can do. Direct action is something that's nonviolent and is meant to create tension and raise awareness so that people have to pay attention to it. And we see that some things like protesting and letters and the media coverage and all of the things that have been happening on the Hill with the sit-ins over the summer has really raised some attention in the current media space. We also know that writing and media attention from op-eds and letters to the editor draw attention to issues. So here's some examples of op-eds. We see an op-ed actually that several snappers, Augie, Vanessa, Brian, and Andy wrote about Medicare for All that got a lot of attention within Stat News. This is a feature article about DACA and the Harvard medical students. Over here on the left is an op-ed that I wrote that ran in the Tennessean, which is the state newspaper for Tennessee, back in the budget process of February, March of 2017, whenever the president was putting forth this new budget. So these are examples of things that can be really valuable, that demonstrate or that create some media attention. And it's always good to engage in these things, but not at the expense of working on trying to build your base in your community. So that's kind of just some fundamentals of advocacy, but I did want to illustrate that these tools apply to many issues. For example, at AMSA Advocacy Day, which I obviously should be talking about some, AMSA Advocacy Day is March 8th, which is the opening day of our convention. You all are welcome to come. There's a discount code for you over on the right. Our Advocacy Day, we're going to be talking about the Higher Education Act of 1965. So the Higher Education Act is the education policy partner to Medicare and Medicaid, both of which were signed into law in 1965 under President Johnson as part of the Great Society era of policy. The Higher Education Act this year is up for reauthorization. The Higher Education Act creates our financial aid and student assistance structure within the United States. And there's a number of things that you can see here that this bill actually seeks to do, including ending subsidization of undergraduate student loans, ending the public service loan forgiveness program, which many medical trainees, for instance, 2/3 of DO students have, according to the American Association for Colleges of Osteopathic Medicine, intend on participating in the public service loan forgiveness program. PSLF is important for people who want to go into medical education, for people who want to work within the VA healthcare system. There's proposals to change income-based repayment plans, other forgiveness programs. Specifically, they want to change federal borrowing limits and restructure the federal direct loan program for health professional students. And as a result of that, with the aggregate borrowing limits, many medical students under this bill, if it passes, couldn't borrow enough money to cover the cost of attendance for medical school. So this is an education bill, but we can obviously see that there are significant public health consequences. And the reason that I illustrate this is that looking at these advocacy and organizing principles, we can recognize that these things apply to many different types of policy. And so we should really think about health in all policies. If you all are interested in coming, we're going to have a congressman keynote speaker, Dr. Richard Bruno, who is very much a single payer supporter. He's running for office in Baltimore, has worked with PHP. He's worked with the National Health Services Corps. He used to be an AMSA national leader when he was in medical students with our Healthcare for All campaign, is going to be there. And I set up appointments for people to go and visit with their legislators and do some training surrounding actually meeting with legislators. But in summary, from this presentation, I hope that you all at least begin to understand that power and privilege really impact systems level inequity, and that upstream engagement in shaping policy narratives is something that has the best public health benefit. And so through doing that, it's not just good enough to have evidence and facts and policy, but we really need to look at how do we challenge power structures to make asks for change, and how do we do so in a way that is rooted in framing and values to make our asks, and not just facts and figures and policy. We should understand that the organizing cycle is something that adapts to political climate, and that building your base surrounding your issue who support it is always something that can be fruitful and encouraging if we do it correctly. And then finally, health is something that we should consider in all policy, not just healthcare and financing and delivery, or in tax or education, but also immigration and security, defense. Any area of policy is something that we should think about with health. So AMSA convention is March 8th through 11th. The SNAP annual summit is March 3rd, LSU in New Orleans. Oh, here are some other resources that I really enjoyed. Anand talked about some resources. Of course, the Kaiser Family Foundation puts out policy articles that Anand mentioned. Vox the Weeds is a podcast that's left-leaning that really dives down into the quote-unquote weeds of policy wonk. Left, Right, and Center is a little bit more center to rightward-leaning to provide some conservative argument or discussion about policy in general. These podcasts aren't exclusive to health policy, but they certainly focus on health policy. The Incidental Economist and Health Affairs are both journals and blogs that are great resources for health policy information. Organizing for Social Change is the textbook from the Midwest Academy that actually talks about the theory behind community and community building and organizing. And White Coat Clenched Fist is written by Dr. Fitzhugh Mullen, who is a physician pediatrician at George Washington University within their School of Management and Policy. And it details his history as a physician in the civil rights movement when Medicare and Medicaid were started, working as a civil rights worker in Mississippi, and how he and his medical trainee colleagues and young physician colleagues broke away from the American Medical Association, founded AMSA, and many other organizations like Physicians for a National Health Program, Students for a National Health Program in the late 60s and 70s in the era of civil rights movement, anti-Vietnam War movement, and it illustrates an important role that advocacy has historically within medicine. So it's a great book, and I would tell everyone to read it. That's the end for me. My email address is EAF, that's Elephant Alpha Foxtrot @amsa.org. You all are certainly welcome to email me anytime that you have questions. Here's all my citations, so we'll stop it there and go for some questions. That was a lot of content. Does anybody have any questions for me or Anand? I think people's microphones might be muted. So if you have any questions, feel free to unmute your microphone. If you have any questions, if you think of questions later, like I said, you're welcome to email me at eaf@amsa.org. Anand put his email address up as well. I'm going to share screen back. I'm going to change screen sharing back to Anand, I think. Okay, I think we see some people commenting in the chat box that their microphones aren't working. Okay, changing presenter back to Anand. Okay, so we've got a question that's typed. I think this is for both me and Anand. What do you think is the best way to share patient stories that are impactful, but not falling into being a voice for the voiceless trap? I think it's important to share stories in other people's words and not your own. So I think it's important to think about not providing your own interpretation of a story, or even really creating space for people to share their own stories. So maybe that means making room on our boards to have people's stories represented that aren't being told. Maybe it means making more space for, underrepresented communities in medicine. It means making space for people for underrepresented communities to be elected officials. One of the best ways to share patient stories is really to make space for patients to do it themselves. So for instance, if you're going to make an appointment to one of your elected officials and go visit with them to talk about single payer as an example, then you all can certainly be more of the policy experts to provide knowledge surrounding single payer, but see if you can find one of your patients or a community person to come with you so that they can share their own story about what it's like to have lost their insurance coverage because their employer laid them off, and let them share their own story. So you could potentially just bring a patient with you. I think if you're going to go to DC and it's not an option to be able to bring a patient with you, then it's important to have strong conversations with your patients and share your patient stories. But then also, one of the things that's really interesting about being a physician is that if you're going to share your patient stories and you're going to share your own experiences taking care of people and the things that you see, then you're not being a voice for the voiceless, you're being a voice for yourself. You're sharing your own experience, and that's really powerful too.
Yeah, I completely agree with all of that, for sure. I don't think there's a way to divorce policy from patients. You always look at policy through the lens of your patients, and you always look at patients sometimes through the lens of everything that has affected them up until this point. As you mentioned, social determinants of health, and policy being one of those major social determinants. I don't think there's a reason to necessarily say that you have to be a voice for the voiceless, as much as just saying that you can't divorce policy from reality, and you can't separate policy's impact on patient care and its profound impact on how we do our jobs, and how we look at healthcare for our patients, and healthcare for our communities, and healthcare of the nation as a whole. So, I've pulled up just a few things before we leave. If you can see my screen, on the PNHP website on the left right here, there is, I think you can see my cursor, hopefully, but I'll highlight it. Here's articles of interest. Here's quote of the day. These two are amazing resources. And then the physician's proposal is right here. And slideshows, I completely actually don't know the password anymore. Does anyone, if you know the password, type in the chat. I don't know if they've updated it recently. I haven't accessed it. Oh, nice. Sweet. So if you type in Paris, thank you, Tony, you'll see all the PNHP slides right here. And one of the really good websites that I always go to, I forgot to mention, but Daniel talked about it, is the Incidental Economist. Here's that website. It's really great. And Health Affairs is probably my favorite journal for healthcare policy. So if I can leave you with one thing, it would be to definitely sign up for quote of the day. So that's it for me. If there are no other questions.
This is Daniel. Thank you all again for inviting me. And like I said, feel free to email me if you ever have any questions or want to engage in any kind of social issue regarding advocacy.
Thank you again for having us.